Good morning. My name is Dr. Jason Waspy. I'm a cardiologist at Mass General Brigham. I'm an associate professor of medicine at Harvard Medical School, and I'm delighted to welcome you all to today's session. I actually am a former New England CPAC chair. I completed my term this past year, but we have very detailed policies around financial conflicts of interest. And so if any of us receive uh, funding over a certain threshold from manufacturers, people step down. So I'm stepping in temporarily to chair this meeting. And I'm very happy to do that. At the beginning of every CPAC meeting, we want to ensure that all speakers disclose any financial relationships with industry as part of that policy that I had mentioned. Every member of the CPAC panel who is present today has met the ICER conflict of interest policy. So I'd like to go through and have each CPAC member introduce themselves, maybe briefly about your work, and note if you have any updates to your declaration for conflicts of interest. I also will just say that this is another slight difference today than in other days. We actually have a few guests from other CPACs throughout the country in addition to our normal New England CPAC. So I'd like to begin. I'll go through alphabetical order with Professor Rena Conti.
Good morning, everyone, I'm so delighted to join today. I am Professor of Markets, Public Policy, and Law at Questrom School of Business at Boston University. I'm an economist by training, and I study the pharmaceutical industry. In addition to the current conflicts, I have a couple to update. The first is that I sit as a advisory board member for the Boston University Medical Group. I also serve as a council member for the New Jersey Drug Affordability Council, and I receive consulting fees from Keystone Consulting and from Greylock McKinnon Associates, all of which I think are outside the work that we are going to discuss today. Thank you.
Thank you. Dr. Martha Gold.
Good morning. I'm delighted to join this meeting today. I'm senior research scholar at the New York Academy of Medicine. My background is as a family practitioner in my clinical practice and then as a public health professional working in the area of cost effectiveness analysis and public deliberation. I have no conflicts to report.
Thank you and welcome. Next is Professor Falkier.
Yeah, hi. Thank you very much for having me. My name is Inge Falkeder. I'm a professor at Case Western Reserve University. I'm leading a gastroenterology group at the Veterans Affairs Hospital, and I'm also a guideline methodologist. And for full disclosure, I've worked on COVID guidelines in the past, but otherwise have no financial conflicts of interest.
Thank you and welcome. Dr. Kim, Professor Kim.
Hello, I'm David Kim, Associate Professor of Medicine and Public Health Sciences at University of Chicago. I'm a health economist. My research is measuring value of health interventions to inform resource allocation. I have no conflict of interest.
Thank you. Don Kreis.
Good morning, everybody, and hello from New Hampshire. As you can see from the slide, I am my state's public utility ratepayer advocate, so I know a little bit about monopoly pricing, but I'm really part of the CPAC in my capacity as a patient and family advocate because I raised to a successful young adulthood a daughter who lives and thrives with cystic fibrosis. And I have no updates to my financial disclosures, of which there are none.
Thanks, Don. Dr. Coopers.
Hi, everyone. I'm Julie Coopers, and I'm the VP of Clinical Engagement at Quantum Health. I assist employers with understanding their healthcare cost drivers and develop strategies to improve outcomes within their populations and mitigate those costs. And I have no conflicts to report.
Thank you. Dr. Mitchell.
Hello, my name is Aaron Mitchell. I'm a medical oncologist and health services researcher at Memorial Sloan Kettering Cancer Center, and I have no conflicts.
Great. Dr. Ribitzer, Professor
Yeah. Hi, my name is Jim Rebitzer. I'm the Emeritus Peter and Deborah Wexler Professor at Boston University Questrom School of Business. I'm a health economist who studies incentives and innovation, and I have no conflicts of interest to report.
Thank you. Dr. Joe Ross.
Hi, everyone. My name is Joe Ross. I'm a general internist and a member of the faculty at Yale in the School of Medicine and Public Health. I'm a health services and health outcomes researcher. While I don't have any conflicts that are directly relevant to the discussions today, just for full disclosure, I'll note that I do receive research funding through Yale from the FDA and from Johnson & Johnson as part of a clinical trial data sharing initiative. But Johnson & Johnson doesn't have a product that we're discussing today. So just want to make that clear.
Thank you. Professor Vale is next.
Good morning, everyone. My name is Stephanie Vale. I'm a professor of pharmacy practice at the University of New England School of Pharmacy, which is located in Portland, Maine. I'm also an adjunct assistant professor of psychiatry with the Tufts University School of Medicine. I am a practicing psych and substance use disorder pharmacist, and I have no conflicts of interest.
Dr. Wadera.
Good morning, everyone. Rishi Wadera. I'm a cardiologist and health policy researcher at Beth Israel Deaconess Medical Center in Boston and an associate professor at Harvard Med School in the School of Public Health here. No disclosures.
Thank you. Dr. Winston.
I'm yet another cardiologist, subspecialty of cardiac electrophysiology. I'm clinically retired, and since retirement, have been the physician lead for a program we call the Professional Enhancement Program at a large multi-specialty group centered in Ann Arbor, Michigan. That is, I teach bedside manner.
Thank you, and thank you for joining. Again, we have a few guests who are not normally on the New England CEPAC, so just very happy for me to have everyone together today. From now, I think I've finished with the CEPAC. I'm going to move on to, we have a series of different experts with diverse expertise who will sort of enrich our discussion. And so I'd like to start with Dr. Omar Escontrias.
Good morning, everyone. Omar Escontrillas. I serve as a Chief Programs and Research Officer with the National Health Council. And aside from what is listed, there's no other conflicts of interest.
Thank you. Lee Purvis.
Good morning, everyone. My name is Lee Purvis. I'm a prescription drug policy principal at AARP, a nonprofit that works on behalf of Americans age 50 plus. And I help lead the organization's work on prescription drug issues. AARP does receive royalties from third-party providers of our member benefits programs, and that includes United Healthcare. However, those relationships do not play a role in AARP's policy or advocacy positions.
Thank you. And in addition to patient experts, we also have content experts and clinical experts. So with that, I will move to Dr. Jason Schwartz.
Sure. Good morning. Hi, I'm Jason Schwartz. I'm an associate professor of health policy at the Yale School of Public Health. I work on vaccine policy and policy making predominantly. No conflicts to disclose. I do want to acknowledge I typically join these meetings as a member of the New England CEPAC, but because I am serving in this role today, I won't be participating in the deliberations and voting, but it's great to be here with you.
It's great to have you here, and we'll have you back in a future session in a different role. Dr. Albert Huang.
Good morning, everyone. I'm a general internist, and that's the role I'm playing today. I'm a professor of medicine and public health sciences at the University of Chicago. In my clinical practice, I care for a large number of older adults, and my research specialty is in the area of medical decision-making around chronic disease like diabetes in the setting of older adults. Nice to meet you. I have no conflicts of interest to report.
Thank you, and thank you for joining us. So as a general matter, when anyone introduces themselves for the rest of the day, including this is people on policy roundtable participants and individuals making public comments, they should announce financial relationships with industry or other potentially pertinent influences on judgment. We will present this information when we have it publicly on slides. Now, if you've already introduced your conflicts to this morning, you don't have to do it again, but if it's someone who hasn't been introduced yet, we would like that to be presented before you speak. So with that, I'm honored to cede to the CEO of ICER, Sarah Emont.
Hey, Jason, thank you so much. It's great to be with everyone today. I will also add Jason Schwartz. Thank you for mentioning that you are usually on the New England CPAC as a member. Dr. Wong, who's joining us today, is also usually on our Midwest CPAC. We are keeping it in the family today, but we're deeply grateful to both of you for participating in these roles for what will be a really important discussion. I'm Sarah Iman, the president and CEO of ICER. You're going to hear from several of my colleagues today. Dan Ohlendorf, our chief scientific officer and director of HTA methods and engagement, served as the senior management team lead for this project. Dr. David Rind, our chief medical officer, served as the evidence author for this report. And on the cost effectiveness side, a longtime collaborator, Dr. Brett McQueen, served as the lead modeler from the University of Colorado, supported by Lisa Prosser, who gave her tremendous expertise for having worked in vaccine modeling for the federal government previously in a consultant role from the University of Michigan. We appreciate that Lisa is with us here today as well. Next slide, please. Typically, when we start an ICER meeting, we're talking about a new medicine for a condition, maybe one we've heard of, maybe one we haven't. I don't think I need to spend any time today telling anyone about COVID-19. We've all had it or know someone who has. We've all faced questions and decisions about whether to be vaccinated. And so we're having a different sort of setup for today's meeting. I wanted to talk about why ICER decided to do its first vaccine review. And that's because we are met with confusion as an ecosystem. The changes at the federal government have led to a lot of uncertainties about what we know about the evidence on the effectiveness and value of the COVID-19 vaccines as well as other vaccines. So when we see an opportunity presented by this amount of confusion, we often step into it, given our expertise. On the next slide, this is also a moment where we're seeing a lot of distrust. There are continued polling results and reports telling us that trust in institutions is at an all-time low. This is also an area where we see an opportunity as an organization that's been doing evidence-based reviews for 20 years to offer something to the ecosystem. So today we're going to talk about what we know and what we don't know about the effectiveness and value of the vaccines for COVID-19. Next slide. We do this because independent expertise is needed now more than ever. When we are thinking about producing information for the ultimate policymakers who have the power to make consequential decisions about price and access, think payers, clinical societies, public health experts, they need reliable, unbiased assessment of comparative clinical effectiveness now more than ever. And we do this publicly because that's how you rebuild trust. You don't do this behind closed doors. You don't do this without inviting different stakeholders to the table. You do this in the public. And what we also hope will be an output of today's conversation is identification of where we need more evidence, where we're desperate for more evidence so that we can make the best decisions to support individual and population health. Next slide. And that's because of where we sit in this healthcare ecosystem. When clinical research is produced, maybe for a new therapy, maybe for a vaccine, it goes to the FDA, where the FDA is answering questions about safety and efficacy. They are not answering questions about comparative effectiveness. They're not answering questions about comparative value. Not a knock on the FDA. It's not their job. It's our job. As the nation's health technology assessment body, we answer those questions and we bring the different stakeholders together, whether they're clinical societies, public health officials, payers, employers, manufacturers, patient groups, because they're the groups that are going to inform the subsequent policies, whether they're public health recommendations, decisions about which vaccines are covered and whether or not there's cost sharing. And again, identifying where we need more evidence to feed back into that clinical research ecosystem so that we have the best available evidence in order to make decisions about price and access. Next slide. And we do this without forgetting that we sit in a healthcare system where rising costs are impacting everyone. It's why we don't shy away from conversations about cost and cost effectiveness, because we want to make sure that decisions that we're making about access to therapies are done so in the context of making sure that we're good stewards of other people's money in service to a more affordable healthcare system. Next slide. And we do all of that by holding two things together at the same time. What's important to the patient and their family in the room, wondering about the options for vaccination, wondering about a new treatment that might be available for their condition, while also remembering all of the people who are not in that exam room, who may be impacted by decisions that we make, we being the royal we here, on price and access to new therapies. Next slide. We are ICER. For 20 years, we've been holding these public convenings where we talk about our judgment of the comparative effectiveness and the comparative value with an independent appraisal committee who keep us honest about those judgments. Today, we're joined by the New England CEPAC with some guest members from our Midwest CEPAC as well. Next slide. We want to be as transparent as we ask everyone to be about their potential influences on judgment and financial conflicts of interest. Every organization that's given money to ICER in the last 12 months is listed on our website. You can find that at the link provided, and you can find details of our conflict of interest policy. Any money that we do take from health plans, provider groups, or manufacturers only supports our policy summit, where we bring people together to try to tackle a big issue in health policy and drug pricing policy. Most recent, it was how we can continue to strengthen the accelerated approval pathway through the FDA. Next slide. This process to get to this point took almost 8 months. When we started this review 7.5, 8 months ago, we talked to patients, clinical experts, manufacturers, and other stakeholders in order to know which research questions we were asking. We went through an extensive process of developing the report. You'll hear more detail about that coming up from Dr. Rind and Dr. McQueen in just a moment. And then we had some external expert review. I want to note here that no one who has participated in external review claims any responsibility for anything in the report. That is entirely the purview of ICER and its collaborators. After public comment and revision, the evidence report was revised and posted. You can find that on our website if you want to follow along through today's conversation, but that informs the debate, the deliberation, and the votes that you will hear today at this meeting. Next slide. We talk about value a lot at ICER because we think that questions of price and access are consequential and need to be grounded in evidence. And so our value assessment framework takes into consideration these aspects in green, which are typically pretty easy to measure. How much better a new therapy is at helping you live longer or have fewer side effects? Does it have an ability for you to get back to work? What kind of costs are associated with the new therapy? And then we have things that are sometimes harder to measure: special ethical, social ethical priorities, benefits beyond health, impact on caregivers. Are there special priorities for a population that we'd want to consider in a comparative value analysis? You'll hear us talk about all of those things today as we talk about the comparative effectiveness and value of the COVID-19 vaccines. But know that this is the framework that we take into reviewing any new intervention in the healthcare system. Next slide. You are just about to hear the presentation of the clinical evidence from Dr. Rind, followed by the presentation of the economic model, a cost-effectiveness model. After a lunch break, we'll have the deliberation and vote of the New England CEPAC, because they will be talking through several key questions about what the evidence tells us about the net health benefit of COVID-19 vaccination. After a break, I will join you again to facilitate a conversation with some leading experts and decision makers on what do we do now with this vote on evidence. Where are we emphasizing gaps in the evidence, opportunities to develop more evidence? What does the evidence tell us, and how should it be part of the recommendations that will ultimately be made by others, not by ICER, not by CEPAC, but by clinical societies, public health officials? They will be considering evidence and value as two pillars of their decisions on recommendations to inform the vaccination schedule for the fall. We'll end with some reflections from the New England CEPAC, and we'll be adjourned by 4 p.m. Eastern Time today. With that, it is my pleasure to hand things over to our Chief Medical Officer, Dr. David Rind. David.
Thanks so much, Sarah. I'm hoping that I have screen control, so we'll see if that works. I'm going to be presenting the clinical evidence, and it looks like I do have screen control. So I want to introduce the members of the team that reviewed the clinical evidence. In addition to me were Avery McKenna and Sophia Casson, and none of us have any disclosures. We're talking about COVID-19. We usually talk about the disease background. Here, the disease background is there was a major pandemic that shut down the entire world. In the United States, there were more than 1.2 million deaths from COVID. In terms of the timeline in the US, the first case in the US was January 20th of 2020. The first death was on February 6th of 2020. Many of you may remember the weekend from March 12th through 15th of 2020, when there had been more than 2,500 cases and the US shut down. On April 10th of 2020, I started working in a COVID clinic. ICER was mostly closed at that point. This was a Friday, was my first day in the outpatient COVID clinic. We saw 8 patients in a half day. 7 of them tested positive for COVID, and I think the 8th was a false negative. We didn't have a lot to do for those patients. We had no therapies. Mostly what we were doing was keeping an eye on them and waiting for them to get sick enough that they needed higher levels of care. We were trying to keep them out of the emergency department. The emergency department was trying to keep them out of the hospital, and the hospital was trying to keep them out of the ICU because we were running out of ventilator beds, as you may all remember. On April 29th of 2020 were the first reports of Operation Warp Speed to develop a vaccine. 7 months after that, we had publications of 2 mRNA vaccines in November of 2020. Rather than show you the results from those trials, this is a webcomic from XKCD that basically shows you those results almost exactly, with the placebo group and the vaccine group, and a legend that says statistics tip. Always try to get data that's good enough that you don't need to do statistics on it. The vaccines were spectacular. I got my first vaccine on December 22nd of 2020. I was near the front of the line because I was still working in an outpatient COVID clinic. Getting that vaccine was, I think, life-changing for many of us. For me, my getting the vaccine made me relax some at work, but more than that, when my family got vaccinated, I was no longer terrified each day I came home from the COVID clinic that I was going to transmit COVID to my wife and daughter. By June of 2021, 300 million doses of vaccine had been administered in the United States. So that was then. Spectacular vaccine, life-changing for the US and the world. But how about now? Well, in 2026, most people have been infected with COVID, have been vaccinated against COVID, or both, and this may have occurred multiple times. The strains of SARS-CoV-2 have evolved, and we have no large randomized trials of the current vaccines in the current population at risk for strains that are currently circulating. Over time, the severity of COVID has been declining. These are hospitalization rates per 100,000, and you can see from 2023 to 2024 to 2025, over the same period of months, we're seeing about a halving year over year of rates of serious COVID. When we talked with patient groups and patients, we heard vaccine concerns that we all know about, but we also heard that the communities most worried about vaccines have changed over time, and that some of the communities that were most worried early on are less worried now, and other communities have become much more worried. We heard about long COVID, fears of long COVID, hopes that vaccine might affect rates of long COVID. And we heard about anger, and we all have encountered anger in the space of COVID and COVID vaccines. But one of the places we heard anger was from patients who had other diseases and felt that people not getting vaccinated was putting them at increased risk for getting COVID because transmission might be higher without a vaccine. We went and looked for best available evidence. And we felt when looking for that evidence that we wanted recent data, that what was true in 2021 was not very helpful now, and that it was more beneficial to extrapolate from recent data, even to populations that hadn't been clearly studied more recently, than using old data in those populations that was likely no longer true. We wanted unconfounded data. People who choose to get a COVID vaccine are likely different from people who don't choose to get a COVID vaccine. We wanted subgroup data, primarily by age subgroups, but also in terms of comorbidities and some other subgroups. And we wanted epidemiologic data in the subgroups we were most interested in. So with that in mind, here's what we found. First, here are the vaccines that you all know about, 3 mRNA vaccines, 1 protein-based vaccine now called Nuvaxovid, the successor to Novavax. The evidence base from primarily for where we had the best available evidence was the 2024-2025 season. And we had test negative studies. We had a study we refer to in the report as the adult CDC study and the childhood CDC study. These are studies that are commonly done for vaccines. And the way these were done is patients showing up in an urgent care or an emergency department and being tested for COVID, and either testing positive or testing negative. And the people who test negative are the controls for the patients who test positive. You look back in time to see whether the people who tested positive had been vaccinated or weren't vaccinated, the people who test negative, vaccinated or not vaccinated, a very good control group, because after all, somebody chose to test them as well. And then you are doing a calculation of an odds ratio. This is a case control design, and that odds ratio approximates the relative risk reduction from vaccination. These test negative studies have a possible flaw in that if the vaccine has differential efficacy against different severities of disease, and we do think that's the case for COVID vaccine, where it may be more effective against more severe disease, patients who are showing up at an emergency department or urgent care, we're looking at efficacy that may be greater than against more mild disease and potentially not as great as against more severe disease. We also looked at the study we refer to as the VA study from the 2024-2025 season. This was a study of VA patients, mean age 71, 92% of them male, almost 300,000, who either got flu vaccine, who got flu vaccine and COVID-19 vaccine. And nearly all the COVID-19 vaccine administered by the VA in this time period was mRNA vaccine. So my colleagues have had to put up with me repeatedly saying what a beautiful observational study this is, and I want to talk to you about why I feel that way. The comparator population is almost ideal. These are people who showed up in a VA clinic and were choosing to get a vaccine for a respiratory virus. Maybe they were choosing to get 1 vaccine for flu or 2 vaccines for flu and COVID, but in both cases, this was a population getting a respiratory virus vaccine. That's a great comparative group. This is within the VA system, and so the outcomes are being captured within the VA system, and we're probably not missing many outcomes. And then they ran a bunch of negative controls. Here's the list, and I'm going to take you through some of them. So you could imagine that patients who are choosing to get the vaccine might be at different risk of COVID than people choosing not to get the vaccine. So they looked in the first 10 days after vaccination when the vaccine isn't yet effective. There was no effect of choosing to get the vaccine on your chance of getting COVID in the next 10 days, 1.00, suggesting these groups were identical in terms of risk of COVID. You might imagine that people who are choosing to get COVID vaccine might have different access to healthcare from those who are choosing not to. So they looked at irrelevant to COVID outcomes in the health system, in this case, tinnitus or getting a hearing aid fitting, relative risk 1.01. So these groups were essentially identical for their access to healthcare. And then you might imagine that frailty could be different, that patients getting COVID vaccine were sicker or less sick than other patients. So they looked at what happened for influenza in the people who did or didn't get COVID vaccine. And the risk of a serious complication of influenza, 1.00 across the two groups. So these two groups were essentially identically frail. This is extremely reassuring that there isn't going to be important confounding in this study. So with that in mind, we relied a lot on the study. Vaccine effectiveness is defined as 1 minus the relative risk. And the VA composite result for emergency department visits, hospitalizations, or deaths was at 28% protection, at 28% effectiveness of the vaccine against that. In the adult CDC study, we saw a very similar number of 33% protection and a higher number in children, 56% protection. We extrapolated that 28% number to adults who didn't look like the VA population, and we used that 56% number for children. For adults who did look like the VA population, we used the VA results. So those extrapolations, you have those first two up top that weren't extrapolations, but we're extrapolating from the VA population to healthy adults under age 65 over a wide age range, to patients with comorbidities. We're applying that 28% protection, and we're even applying it to pregnant women. And you might consider how much you're willing to trust the result from 71-year-old men when applied to pregnant women, but we still thought that was a better choice than trying to use old data in pregnancy that we didn't think were accurate in 2026. For newborn babies, we didn't really have any good data other than biologic plausibility. We know early in the pandemic that vaccines protected newborns. We know from recent studies that antibodies are transmitted, including antibodies from administration of vaccine to third trimester pregnant women. And we know that other vaccines are protective for newborns when administered to third trimester pregnant women. In terms of vaccine harms, we all know about fever, malaise, and aches. If you didn't get these with the COVID vaccines, you certainly know people who did. These were more likely to happen with the mRNA vaccines originally than with the original Novavax, now Nuvaxovid. But even more recent studies suggest that the mRNA vaccines have higher rates of this sort of reactogenicity than the protein-based vaccine. And then there's the question of myocarditis. In 2021, we saw very rare but important cases of myocarditis sometimes, most often happening in teenage boys and young men. And after 2021, those rates seem to have gone back down to what we see in the background in the population. So that raises a question as to whether there is still a risk of higher likelihood of myocarditis in certain populations after vaccine. And it's possible that that risk has gone away either because of changes in the vaccine, changes in the population, changes in the vaccine schedule. But we weren't certain of that. We continue to worry to some degree that it may in part have gone away because the people most at risk, family members, teenage boys, whomever, are choosing less often to get vaccinated because of this risk. And so this could be confounded. In terms of the epidemiology that we see, you can see here that newborns up to age 6 months have the highest rate of hospitalization for COVID until you get to people over age 75. And then you see the sky-high rate in people over age 85. We take those epidemiologic estimates, we apply the numbers from the studies I talked about, either directly or by extrapolation, and we get the number of people needing to be vaccinated to prevent one hospitalization or needing to be vaccinated to prevent one death. And I highlighted these fairly low numbers within this. For children 6 to 12 months old, it's 1,000. We didn't attempt to estimate prevention of death in children. We didn't feel we had good enough data. And note that we don't have newborns here because this was just biologic plausibility. We didn't feel we have good numbers there either. For adults, for instance, over age 85, you just need to vaccinate 300 to prevent one hospitalization and 1,000 to prevent one death. In terms of uncertainties, we think that this may be a conservative estimate for a number of reasons. Again, that 28% composite, it may be higher against more severe outcomes, and it may be that as you get into younger patients, the benefit is better. Additionally, there was just a publication of a 2025-2026 test negative study that had vaccine effectiveness rates in adults of 48 to 50%, much higher than that 33% we saw. That's a preliminary result, but you should know it's out there. On the other hand, that study also commented that rates of severe COVID have in fact continued to decline. So those two things may offset each other. Maybe there was more protection, but also the rate of hospitalization and serious illness was lower. The extrapolations we talked about, particularly extrapolations to groups like pregnant women from 71-year-old men. We assumed no benefit on transmission, or at least no important benefit on transmission. There may be some benefits on transmission. We do not think they're large, and in any case, we didn't think the data were good enough to include in our evidence ratings. In terms of the forms of long COVID, and when people say long COVID, they mean a lot of things, but the form that occurs after non-severe disease that looks like a chronic fatiguing illness, there's been hope that vaccine might reduce long COVID, even potentially in people who had asymptomatic COVID. We didn't feel that we had adequate data to conclude that. We understand the hopes for this, but we don't think the data are there yet. We got a number of public comments with concerns about how our report might be interpreted. And we want to state again that we are not making recommendations for public health. We are assessing the evidence for net health benefit of the vaccines. Public health decisions have to take in that evidence. They need to take in cost effectiveness. They need to take in implementability, ease of understanding, and many other things. We are not making recommendations. With that in mind, let's go through our evidence ratings. Our highest evidence rating that we gave in this report was a B+ rating, saying that we're sure that we have at least a small net health benefit and maybe a large net health benefit in adults over 65, women during pregnancy, and we're including that the benefit to the newborn, and children under age 6 months. These are high-risk groups, and we think that the vaccine is at least providing small benefit. In children ages 1 to 2 and people under age 65 with comorbidities, we think that there's no chance the vaccine is ultimately providing net harm. It may be providing a small benefit, or it may be providing a large benefit. In adults who are healthy and children who are healthy, excluding males ages 12 to 24, we don't think there's a possibility of net harm, and we think there may be as much as a small benefit, but not a large benefit. In males aged 12 to 24, we include the possibility of harm because of our uncertainties about myocarditis. That doesn't mean we think there is harm. We don't think we have adequate data to be certain there isn't harm. We think it's possible that the vaccine provides a small net health benefit. The promising but inconclusive rating that we give, the PI, includes substantial net health benefit, but we don't actually think that's possible here. We think the best you could get in males aged 12 to 24 is a small net health benefit. In terms of comparing the vaccines against each other, the vaccines have different rates of reactogenicity. The protein vaccine causes less fever and malaise, but we don't have adequate data comparing them on efficacy. And so we rated this as insufficient evidence. We don't think we can know whether some of the vaccines are a little bit more effective than other vaccines. They all work. In terms of benefits beyond health and special ethical priorities, we noted that some populations like Blacks, American Indians, and Alaskan Natives are communities that have been at increased risk for COVID and have been historically disadvantaged in the United States. We note that low socioeconomic status has placed people at increased risk from COVID, and that made up a lot of our frontline workers, the essential workers who kept us fed and did other things early in the pandemic. And that includes healthcare workers. When I was working in that COVID clinic early on, there were medical assistants there who were very low paid, putting their lives at risk to make sure that we could care for outpatients who had COVID. So in conclusion, the risk of severe disease from COVID-19 is declining over time. There are still subgroups at high risk from COVID-19. That includes newborns, infants, and adults over age 65, and particularly over age 85. There are still subgroups at increased risk from COVID-19, but not at high risk. Young toddlers, pregnant women, people with comorbidities. Vaccines reduce this risk. Vaccines cause frequent minor harms and very rare severe harms. Thank you.
Thank you, David, for that presentation and for the tremendous work in this report. You and Avery McKenna and Sophia Cassim and Maddie Booth and everybody. It's really so many comparisons and so many really tricky issues in comparative effectiveness research as you've outlined. So thank you to you and the whole research team. We have some time for questions for the CEPAC, and I know I have a couple, but I want to make sure that other people have a chance to get in first. Please use the raise hand function. The SMT lead, Dan Ollendorf.
Wow, this is scary.
I just want to clarify something. So slide 47, the B plus slide incorrectly lists children under 6 months old. That should be children 6 to 12 months. So clarify that for people. So less than 6 months, not eligible for the vaccine.
Right. They're only getting it through the pregnant women. Right. Yes. Sorry about that.
Right. It's just an incorrect label. That's all. So think about it as children 6 to 12 months.
Right.
Right.
Thank you both for the clarification. Any questions from anyone else? Jim.
Thank you. That was a really outstanding presentation, and I learned a lot from it. I have one question about the VA study, the remarkable VA study that you emphasize. And it's a concern. It's not something I feel I know. My concern is that the method will understate the potential benefits of the COVID vaccine because, well, in any observational study, you got to ask why some people got the flu and some people got the flu and COVID vaccines. And with the widespread availability of testing at home, you worry that one of the reasons that people didn't get both, they got one, is because they recently got sick and did an at-home test and had the vaccine. And if that's true, I think that would understate the measured effect of the comparison. And I don't think that that concern would go away by the fact that there are similar rates of COVID immediately afterwards. So that's a really important thing you raised in your discussion, because if you recently had COVID, it's sort of almost like you were vaccinated. So that doesn't invalidate anything. I just think that where this method, this observational study, is carefully controlled as it is, might lead to more conservative estimates than if we had a true randomized trial.
I'll try not. I'm not going to go into that in depth right now, but I'm not sure I buy that that's the direction that it would move if that's a correct assumption. because of course those people, they knew who had bad enough COVID coming in to have been hospitalized or something like that, and that was not among the population who could be in the study. So we know at least that that was a group of people that didn't have anything bad happen if and when they got COVID. So it's a little bit tricky in understanding what that would mean. David?
Thank you.
Yeah, thank you, David. That was amazing presentations, really thorough, comprehensive, learn a lot. One things that I was curious about, one things you didn't touch about the waning vaccine efficiency over time. I'm just curious that, what you find out from the either VA studies, CD studies, or prior studies, and how we should understand a waning effectiveness over time.
So this is captured a little bit in the economic analysis, but I think that the right way to view it is that if you get a vaccine in the fall of this year, a few months from now, you're buying yourself protection for about 6 months. And that either because of waning of antibodies or because of drift of the virus or both, you're not going to have a lot of protections from 6 to 12 months. It's not that you have no protection, but it's not a lot at that.
Other questions or points? Dr. Gold.
David, could you talk to us a little bit about the transmission issue and evidence and how you guys reviewed the information and what's available to extrapolate from?
Sure. We know from various studies, both early in the pandemic and now, that effects on transmission are not huge. That's not to say that we know for certain that they're zero. And so at an individual level, if the question were, I really don't want to transmit the virus to a family member, is there any value at all to my getting vaccinated for that benefit? I suspect there is a benefit to that. I don't know how large it is, but there may be a benefit. At a population level, if it's there, it's quite small, and you can come up with stories in which it goes in the wrong direction. We know that asymptomatic people can transmit virus. And so if getting vaccinated increases your chances of having asymptomatic COVID because you're not as sick with it, you might go out more. So I had a cold last week. You may all be able to hear that in my voice a little bit. And I was wearing a mask all the time I was coming in contact with people because I had a cold. If I hadn't had a cold, I wouldn't have been wearing a mask. And if I had asymptomatic COVID, I would have been more likely to transmit it because I didn't have a mask on. So it's a little bit hard to know what happens there. We didn't feel that our evidence ratings would have wide, we tried to create varying levels of confidence around our estimates. We thought that those estimates encompassed what we believed possible for transmission. But if you think we're very wrong on transmission, you might come up with a different answer.
It's interesting because you discussed being vaccinated and coming home to your family and wondered how you felt during
Oh, that was in 2021.
Yeah.
In 2021, at the very beginning, before the vaccine, before the strain drifted, even. So this is before what happened in P-Town in the summer of 2021. On the earliest risk, I think we did think, and probably were correct, that the original vaccine against the original virus probably did reduce transmission.
David, I'll just say that one of the many things I loved about your report and your presentation was that you said things that resonated with so many of us. A lot of us were taking care of the patients. We're worried about infecting our kids, and we're so so happy when the vaccine and really achievement of modern medicine, and no question about the efficacy as measured in 2020. I really loved your presentation because a lot of that resonated with me, and I'm sure others on the panel. We've also talked about trust, especially in Sarah's introduction. I think my hope for me, and I hope for our panels, is to sort of build trust with the public, to build trust in medicine, to build trust in science. And part of how I'm trying to do this as part of the deliberative panel is to really self-examine my own biases and assumptions a little bit. I'll say like I'm not hearing a lot of evidence that this reduces transmissibility. It wouldn't be normally sufficient evidence to say, well, we haven't disproved that. I mean, am I right there? It doesn't sound like there's any real evidence.
I think that's correct. We have not proven the negative of this, and we did try to treat this the way we treat all our reviews of not counting things in favor of the vaccine just because we hadn't proved it wasn't a benefit of the vaccine. And similarly, on the harm side, if you ask me, I don't think there's much risk anymore of myocarditis with the vaccine, but I would never view the evidence we have right now on myocarditis as good enough for some new oncology drug that came along and said, well, we don't think there's a risk from our drug anymore. We think we figured out a dosing spacing and it doesn't cause myocarditis anymore. I'd say, I want you to prove that. And that was how I felt about the vaccines when we were looking at it, even though if you ask me what my best bet is it doesn't cause myocarditis anymore.
Yeah, no, I just appreciate your tremendous rigor in kind of thinking through this. I'd love to also hear from the clinical experts and the subject matter experts. If anyone wants to weigh on this issue, you certainly don't have to. I just wanted to give people the opportunity. Jason.
Yeah, I'll just note, these questions about designs, the test negative design, has been noted, it's been in the news, gotten headlines about some of the arguments about the strengths and weaknesses, and particularly perhaps the limitations of those designs. Worth noting, as David indicated with the most recent study published just in the past few days, and a nice accompanying editorial describing the role that test negative designs play in respiratory virus effectiveness studies for COVID and for influenza, is the long-standing, for decades, model, warts and all, limitations and all, as any design has, but provides the kind of evidence that has served as the foundation for both how we think about influenza vaccine effectiveness and how that's been brought over here to COVID. So I think there's been lots of work to try and appreciate some of the strengths and weaknesses, innovate in those designs, but quite typical kind of foundation for what decision makers have had to go on for respiratory viruses, particularly those that require these year by year kinds of assessments, as COVID has come to done based on the flu model. So I think what we're seeing here are important issues that are important to this conversation today, but as I suspect we'll talk about later, are also important to how we think about the evidence base for these class of interventions as well.
I will say that as we were doing our analysis of this, and because we haven't done a lot of vaccine reviews before, I had spent a lot of time thinking about test negative designs, and we had started thinking about it and understanding the pluses and minuses of those designs before it all exploded in the news a bunch of months ago, and an MMWR report was suppressed as a result. So it's not that often that statistics issues that I'm in the middle of learning show up in the news with arguments in the press and, on NPR and in New York Times Daily and things like that. It was unusual.
Oh, well, it's a good time for us to deliberate on these issues then. Dr. Huang.
Yeah, I have just a little bit of clinical insight from, and Jim's Professor Rabitzer's comment maybe sort of, I've been thinking about this VA study a lot because when many of you who actually provide primary care to patients will sort of have this experience when you're faced with deciding what vaccine to offer, especially in the flu and winter season. It's actually not one thing; it's two or three things. And so, how much of what we saw in the VA is due to patient preference, or is it provider uncertainty about the strength of evidence around COVID-19 versus the influenza? All of that's in play as you're interacting with a patient and making a decision. I guess if it ends up being largely preference-based and not clinically based, and maybe that's what the New England Journal paper, what it shows is that actually it was not based on clinical decision-making, then what we see is probably due to just random differences in people's preferences. And then we can probably believe the evidence from that study. But I'll revisit this later on in the policy roundtable. But there's actually a constraint in time and how much you can discuss with the patient about each vaccine that is a real limit to how we can deliver. I think the number needed to vaccinate was in thousands. That's a lot of people still. And we'll talk about this later, but the number needed to vaccinate for other vaccines is far lower or far higher. And a primary care physician who's thinking about this will think about that.
So I would say, Albert, that without the negative controls, I was very worried about that when I opened that paper. I was unaware of what I was going to find when I read the New England Journal paper. And I was thinking exactly that. These are people who chose to either get or not get. The doctors were making choices, all of that. And then you look at the negative controls and it's like, I can't see how these are not equivalent groups.
Dr. Conti.
Thank you so much. I want to compliment David and the analytics team for an absolutely outstanding report. I think this is one of the best reports I've read by ICER and the team. I have 3 comments that actually all touch on comments we've already had. The first 2 are about the FDA review of this vaccine. And I wondered whether the concerns about number 1, transmission, and number 2, the myocarditis, gave FDA pause, or was something that they asked the company to do additional studies of to try to find some evidence so that they could inform that could inform their deliberation. These are long-standing concerns related to these vaccines, and it seems like this is something that is so in the public awareness now that FDA also has a duty to really think through these issues. And then lastly, the number to treat um, in the report and in your summary, that made me think that actually, as a clinician, which I'm not, I might worry a little bit about getting to that level of vaccination in specific communities, and that whether that would actually tip me into wanting to recommend vaccination to my community. And I think Albert's comments would be, I think, very helpful here. Thank you.
I'm hesitant to think that I know anything about how FDA was deciding things at the time you're talking about. I don't know if Lisa Prosser, do you have any feel for this? You're muted right now, Lisa.
Thanks, David. I do not have any insight on how the FDA viewed this, but perhaps just a note to say that the myocarditis data did originally come, I believe, from the CDC through the Vaccine Safety Data Link, or VSD data, and then they used other supplemental data to look at that risk over time, comparing both the risk of myocarditis from vaccines to the risk of myocarditis from COVID infection and illness itself. But I do not believe that that was generated by the FDA. It was the CDC that was investigating it.
Thank you. We have about 1 more minute, and I see Joe Ross's hand up.
Well, and this may come up later. Well, first, I also want to congratulate the ICER team on this really clear, well-prepared report. I learned a lot by reading it as well. I just want to pick up on the comment that Albert and Rena just made around the number needed to vaccinate, because that number is obviously going to be very different for different types of vaccines. And I'm just wondering, David, in the review, if you looked at, or how did this compare to other respiratory viruses? I think flu is probably the most comparable vaccine. And these numbers, I think, look similar, but I don't know if you looked at it more formally. I don't think there are other respiratory viral vaccines to which to compare it in order to get at these NNVs outside of transmission?
So I don't have a strong background in vaccines. And so in the report, what I did, and which I think caused a bunch of infectious disease people to go, what the hell, is compare this to other primary prevention activities like statins, and looked at groups that we would often question or decide to give a preventive therapy like a statin to, and make a decision that way, rather than treat vaccines that don't affect transmission very much as its own special group. Whether that's fair or not, I will leave to all of you, but I'll just tell you that's how I approached it. I said, gee, if it's not affecting transmission, it's just a preventive therapy like any other preventive therapy. Let's evaluate it that way. And that was how I thought about it.
Thank you, and thank you all for the good conversation. We're going to have more time to deliberate on some of these issues and ask more questions later in the day. With that, I'd like to transition to the next presentation from Professor Brett McQueen from Colorado to talk about the economic modeling.
Thank you, Jason, and already great discussion. So Brett, Associate Professor from University of Colorado. If we go to the next slide, please. Joined by our team Antal and Harry from Colorado, and then our special guest author, Dr. Lisa Prosser, as well as Marina and Marie from ICER. Next slide, please. I do want to report I have received consulting fees from Sanofi unrelated to vaccines. It's in the area of type 1 diabetes, which I'm quite passionate about. Otherwise, no disclosures to report. Next slide, please. So the aim of this analysis was to evaluate the cost effectiveness of the updated 2026 to 2027 COVID-19 vaccines, again, with that revised FDA labeling compared with no updated COVID-19 vaccination. Next slide, please. Next slide. So I'm going to present to you both a healthcare sector perspective as well as a modified societal perspective. And it has sort of an interesting result, and we'll get there when we get to the results. Our model design is a one-year decision tree to capture all of the effects during that 2026 to 2027 season. And then we transition to a lifetime Markov model to estimate any potential long-term sequelae really derived from severe COVID-19 that may extend beyond that first year. Our outcomes are total and incremental cost per equal value of life year, quality adjusted life years, and then we have a clinical outcome of hospitalizations per 100,000. Next slide, please. All right, so let's jump into the model. This is fairly consistent with Dr. Prosser's model. If you start on the far left-hand side, we are modeling the potential adverse effects of an updated COVID-19 vaccination. Our other arm is no updated COVID-19 vaccination. And then there is symptomatic COVID as the next step. And if you end up getting COVID-19 and it's symptomatic, we really characterize that through non-severe COVID-19, so no hospitalization, versus severe COVID-19 with a hospitalization. So let's start at the top. There's still a chance of encountering some sort of medical or third-party help. That includes an outpatient visit or an ED visit. There's even sequelae after non-severe COVID-19, but we assume that that's resolved during this one-year time period. If we move to the bottom, hospitalization is broken up by ICU, no ICU, and then within that ICU category, ventilator and no ventilator. This is really where the excess mortality comes in during this first year, is that severe COVID-19 arm. And then we transition severe COVID after this first year to the Markov model. So if we go to the next slide, you'll see the sequelae after severe COVID-19 is modeled both through ICU and no ICU. This lasts at the deterministic or the mean level approximately 3 years before its patients then move to that resolved state. We do vary that from 1 year up to 5 years. After the first year, we don't include any excess mortality, but some of these severe sequelae, for example, may include post-ICU syndrome or potential organ damage. So that's all included here. The one final note about the long-term Markov model is that we are including, and this allows us to model, the life that otherwise would have been lived had a patient not died during that first year. So that's going to be really crucial as well. Next slide, please. All right, so let's jump into characteristics and key inputs. I'm going to show you something that isn't very common in ICER reviews, and that's a pooled estimate across different age groups and different high-risk status, defined at least by COVID-19 CDC criteria of having at least one comorbidity. So right off the bat, you can see that ages 50 and above are going to be really the biggest group in this model, and that's going to affect the pooled results. In the report, you actually can view the supplement where we break results down by each age subgroup. Next slide, please. We have a number of key assumptions. You can read all of those in the report. These are just a few that we feel are important. So the first one, in terms of vaccine effectiveness from that VA study, we're really talking about incremental protection above baseline immunity. That's either from prior vaccination and or infection. And then obviously we're not in the 2026 to 2027 season. So we are relying on evidence from the most recent season, which is the 2024-2025 season, with data available to apply to things like emergency department, hospitalization, and death. We did include waning over the 2026-2027 season in terms of really an average to account for hospitalizations happening at certain spikes during that year or that season. But we don't include any waning beyond year one. Finally, and I kind of already explained this, but I want to reiterate that any sequelae after non-severe COVID is really resolved within that first year. And then after about 3 years for severe COVID-19, we only include the excess mortality for severe sequelae for year one. Next slide, please. All right, so we'll start off, and the inputs that I'm going to show you are really key to the model and its driver of cost effectiveness estimates. The first one, of course, is symptomatic COVID. And then from there, there's a conditional probability of hospitalization. And that varies by each age group. As you can see, it increases as you get above 50 years of age. Next slide, please. We then apply effectiveness estimates. And you might be looking at this and say, hey, this looks different than what David just presented from the VA study. And that's true. It's because we're disaggregating the effectiveness estimates by encounter. So for example, outpatient, hospitalization, with or without ICU, which also varies by age group. Importantly, when we re-aggregate, or what we would call roll up the decision tree, in another sense, it's a weighted average, we get to approximately the same composite effectiveness estimate as the VA study, or around 30%. Next slide, please. Unlike other ICER reviews, the CDC is a major purchaser of vaccines, and especially through the Vaccines for Children program. So you can see already that there are different prices by different age groups. That's going to kind of come out in some of the results. I'll point some specific examples out to you when we get there to the results. Next slide, please. So our costs for these different events, for example, hospitalization, ICU, non-ICU, really come from a national market scan data analysis that went unpublished but was cited in Dr. Prosser's work. And then we do include the cost of mortality. That's based on a regression algorithm that predicts death by age. Next slide, please. So in order to calculate equal value of life years as well as quality adjusted life years, we start with the average American's quality of life, and then we have utility decrements that are related not only to symptomatic COVID as well as, for example, hospitalization, but we also have disutilities associated with the vaccine itself and any adverse events. So that includes reactogenicity, myocarditis, anaphylaxis. This is an area I'm going to point you to because there are going to be differences that we see that show up in the results. Next slide, please. All right, so we are there, and I'll have you start first on the far left-hand side. Again, this is the weighted average price. That's why we see some differences, especially since some of these are only indicated for certain age groups. So that's why you're going to see some differences. There's also administration costs. And then we start seeing how the reduction in hospitalizations plays out in the non-intervention costs column. So you see that with no vaccine, there's a reduction as you get to each one of these vaccines. Overall, though, we still see an increase in the total cost, a very small increase in the total cost. And with that comes a very small increase in total benefit. First, when we see hospitalizations per 100,000, we see that reduction. And then that plays out. That's why we have so many decimal points, because it is a very small benefit across quality adjusted life years, equal value of life years, and life years as well. So we're in this scenario where we have a really small increase in cost and a really small increase in benefits. Let's see how that plays out on the incremental results slide. So first thing to point out, and I mentioned this before, Nuvaxovid and mNEX Spike are FDA indicated only for age 12 plus. So we assumed no individuals were taking a vaccine from 6 months to 11 years. So that's just kind of an important point first. But for that increase, that small increase in vaccine cost and that price and that small increase in benefit, we're still meeting commonly cited cost effectiveness thresholds across quality adjusted life years, equal value of life years, and life years gained. We also show you the cost per hospitalization avoided. There is no threshold to compare, but for your own review and knowledge to understand, that's why we included it. Next slide, please. All right, there are a number of key drivers, but really we're focused on the probability of hospitalization and then the vaccine effectiveness against that hospitalization. These are really the two biggest drivers of the model, as we would expect. And even when we lower them from the lower all the way up to the upper, we still see they do not meet commonly cited cost effectiveness thresholds of 100,000. Next slide, please. All right, so when we vary not just one input, but we vary a bunch of different inputs, we recalculate the model maybe 1,000 times. Then we can calculate the proportion that meet these different thresholds. Consistent with our deterministic results, we see the vast majority of these simulations meet commonly cited thresholds at 100, and then all meet at 150,000 per EVLY. Next slide, please. We also ran a number of scenario analyses, and I do want to touch on that. I did forget to mention that in the base case results, you'll see a discrepancy between the total cost arm and the final. If you're looking at the evidence report, there is a discrepancy there, and we're going to fix it for the final evidence report. What we're presenting today is correct. So I just wanted to make sure I mentioned that since I forgot on that slide. The first one that might seem somewhat counterintuitive in terms of the scenario is the modified societal perspective. You see that increasing above the 100,000 per EVLY threshold, and really that's because the savings from the reduced severe disease, so hospitalizations, just did not offset not only the cost of the vaccine like we already saw, but also the lost productivity from the adverse events. And you'll see that there's not a big difference in Nuvaxovid there versus some of the mRNA platform vaccinations. So that's why there's that discrepancy there. It's quite an interesting result. I'll also point out scenario 2. So I've already mentioned that, hey, maybe in the 26 to 27 season, maybe it's slightly better in terms of hospitalizations, meaning there are fewer hospitalizations. We took the lower bound of the 2024 and 2025 season and then applied that to the scenario. We still see that it meets commonly cited cost effectiveness thresholds. I'll finally point out scenario 6, where we have a vaccination for all individuals greater than 6 months, irrespective of risk status. And then that's when we start seeing some of these estimates exceed 100 and 150,000 per EVLY. Next slide, please. So we did calculate health benefit price benchmarks. I think it's just mainly to note they're already meeting commonly cited cost effectiveness thresholds for each vaccine. So it's just that no discount is needed in this case. Next slide, please. All right, we had a number of limitations. I think the first one that I've kind of spoken about a couple of times, we're limited not only in the generalizability of the population outside of the VA, but also populations in the 2026 to 2027 season. We tried our best to give you that scenario that I just spoke about. And then we really ran into some issues around data lacking, not only on epidemiology, but also on long-term sequelae, again, particularly in that pediatric population for epidemiology. The last thing to note is we're only talking about the net impact of one vaccination. So any additional doses, those are uncertain. We would have to weigh the additional benefit against the costs of that additional vaccination. Next slide, please. All right, so we received a number of really helpful comments. We thank all of you for participating. In between the draft report and this evidence report, we did receive updated pricing. So please review the most recent version of the report, as well as the slides here. That'll be the most up-to-date results. We had some limited evidence on long-term sequelae. We had some really helpful comments on how to position that and made a few updates. And then some of our productivity loss and adverse event assumptions were also updated. So we thank everyone for participating. Next slide, please. All right, so to conclude, administration of the COVID-19 vaccination for the 2026-2027 season adds a little bit of cost to the healthcare system at current prices, but has enough benefit that we would meet commonly cited cost effectiveness thresholds. Obviously, the key driver, which hopefully stuck out to you, is the effectiveness against hospitalization, those severe events, and then of course that baseline of hospitalization itself, conditional on exposure. The other thing I've noted a couple of times, that individuals at or greater than 50 years of age contributed really the greatest weight to these results. So we should also take that into account. You can find the disaggregated results in the supplement. So we give it by age group as well if you have interest in that. So at this point, I think we'll move to questions.
Thank you to a great report and great presentation. And thanks to you, Brett, and the entire economics and modeling team. I already see we have a question. Don Kreis.
Thank you. I just want to confess here that I am perhaps the only lay person participating in this CPAC today, and I'm also somebody who has a visceral, deep-seated love of vaccines. I am ready to roll up my sleeve as long as somebody can assure me that the vaccination will not kill me. I'm just so committed to that as just an incredibly awesome public health initiative. But as the layperson, I want to lift up a comment that I read from the Alliance for Aging Research because it resonated with something that I found myself thinking about as I read the report. And their comment was basically about the propriety of using QALYs and its related metrics to assess these vaccines, given that QALYs really measure health improvements after a person's already sick rather than the value of prevention. And the answer that ICER gave to that expression of concern was basically, well, we've always done it that way, and so has the CDC. And I get that, and I want to inoculate myself against criticism by saying that I love QALYs. I'm going to put QALY on my license plate someday. And so I support the use of that metric generally, but I wonder if somebody could, screening out the "we've always done it that way" justification, explain to me why it is, in simple terms, that QALYs are useful in determining the cost effectiveness of COVID vaccines.
I think maybe just given the nature of the question, should I also invite Dan Ollendorf, the SFT lead for health economics, to weigh in on ICER's approach to this?
I'm happy to kick it off, David.
Right, yeah, go ahead. Sorry.
I think it's a good question to ask globally. I'm not going to speak for ICER and their value assessment framework, but what we're talking about in this review with vaccines. Dan, did you want
to? Yeah. So, sorry, I'm having trouble with my volume controls. Apologies. So Don, appreciate your question. I would probably beg to differ. I don't know that our response was simply that we've always done it that way. Uh, there is no reason to discount a measure that will consider improvements in the length and or quality of life for a preventive technology, just as you would with a treatment. So the reason that QALYs and other measures have been, life years gained for that matter, have been used to try to understand the benefits of vaccines is that you are taking a population-based approach to inoculating that group against relatively rare events. And so you really want to try to understand the cost introduced by that program, as well as the clinical benefits that might be achieved, even though the vast majority of individuals you are vaccinating will never experience that event.
I just want to, if I could just quickly, and my team will keep me honest here. Don, to me, it's just directionally, when we're looking at a treatment for a condition, you are looking at improvements in health gain, and you can use the QALY or our primary metric, the EVLY, to do that. If you're looking at a preventative treatment, you're looking at avoiding harm. So you still need a metric to measure the harm that you're avoiding. So to me, it's just directional. And I hope that resonates with everyone else and as a way to think about it and why it was appropriate to use the EVLY.
And I also think, Don, I think it's important, and I kind of hinted at this in the presentation. I only mentioned it once. It's really important that we, regardless of whether you're using life year or quality adjusted life year or EVLY, which is ICER's primary metric, we want to understand the life that could have been lived if you didn't die during that first year. And really only a cumulative measure that takes into account life lived after the first year of that mortality is going to help us understand the value. Because if we stop at that 1 year and we use some sort of clinical metric, which is still very useful, we would avoid understanding that if I didn't die of COVID-19 during 26 to 27 season, maybe I could have lived until 2035, right? So that cumulative estimate, whether you use a life year or quality adjusted life year, is really crucial in understanding the value of especially vaccines, but other interventions as well.
I just wanted to say thanks. That's helpful than simply saying, well, any departure from this approach would break important and long-standing precedent, which I rather glibly paraphrased as we've always done it that way.
Dr. Gold.
I've got two questions, one for Lisa Prosser and the other for the team that did the actual modeling. So, Lisa, just give us a sense of what cost effectiveness ratios have been for other vaccines, just so we know where this kind of fits in the vaccine economic
Sure.
reviews.
Yeah, great. Thanks for asking that question. If there has been a body of work looking at retrospectively vaccines that have been approved and recommended by the ACIP, and as we all probably know here, there is no single threshold that the ACIP has used in the past, and I'm speaking about the prior ACIP. There is no functioning ACIP at the moment. Has used to determine what that value would be for vaccines. But if you look generally at kind of what has been approved, there is a range that goes from cost saving all the way up to about $150,000 to $200,000 per quality for those vaccines that were recommended. There are some that have been recommended that have been above that threshold, but again, those decisions, like any health technology assessment decision-making process, are based on what CDC uses as an evidence to recommendations framework, which includes economic evaluation as one factor into that overall decision-making. And that's where, among those deliberations, those vaccines that are outside of that range that we see most vaccines falling into in terms of cost effectiveness, have been justified in terms of other areas of the evidence to recommendations framework.
Can you just mention a couple of those that have been on the high side, just for all of us to be familiar with?
Oh, sure. So one of them was a meningococcal vaccine for adolescents, where there was a essentially discussion around what the optimal age was, which was slightly different in terms of optimal cost effectiveness, but in terms of coverage, that they aligned that with entrance to college instead of a year or two younger, which would have aligned with kind of the more favorable cost effectiveness ratio. So that's just one example.
Thank you. And the second question I have is whether there was any thought about trying to model transmission issues. I imagine that that would be as part of the scenario analysis. I know that that would probably be very challenging, but I'm curious to know whether there was conversation about that because it doesn't appear in the report.
Yeah, thanks for that question. We did have extensive conversations about that really early on and consulted with Dr. Prosser about that as well. So we stayed consistent with the CDC on not modeling transmission, and Dr. Prosser has also noted that there's no real modeling of influenza transmission as well. And it's just a lack of evidence, and then also combined with the lack of herd immunity. So I think those factors led to us saying we really don't have enough evidence to even do a what if scenario. But it's a really good question. We did discuss that in detail.
Thank you.
Jim.
Thank you. Brett, your presentation was really useful for me, and in part because it asked us to focus like a laser beam on a particular subset of the problem, which was hospitalizations. And that made me think about the long-term economics here. Right? The hospitals are like utility grids. They have to if they're well run, they have to staff towards peak load, right? And that's expensive.
Yeah.
And these diseases like COVID and flu, they come in waves. And so they influence the peak load of strain on hospitalizations and COVID and ICU and stuff like that. And so even a modestly effective vaccine could have a very profound effect on what your peak load staffing, and that's peak load capacity rather, and that would seem to be a very important aspect of the economic consequences of the COVID vaccine. And I didn't see it. You're in your discussion or your report where you discussed it, and if I missed it, great. And if you just chose not to discuss it, what are you thinking about that?
Yeah, so we didn't identify individual hospitalization sites and the load that they may take during these peak periods, but we did a couple of things that I think are important, Jim, to note. First, our estimates are sort of a weighted average, so that includes some of the peaks and valleys that you see. So we adjusted for that. The other thing that we note is the cost per hospitalization and the hospitalizations avoided. But the key with this model is that we're spreading it out or we're averaging out over the course of the entire population. And so even the small reductions in hospitalization represent a small reduction in the offsets. So the cost offsets are included across that big group of people. But we also have to realize that if we're vaccinating, just among the age 50 and above, something like, almost 100 million people, we have to weigh that against about a conditional probability of 5% of ending up in the hospital. So that's really what we're doing in the model, is weighing these different trade-offs of let's vaccinate a big group of people and then see the downstream events. So it's embedded in the model. However, we didn't really spend time talking about like hospital load and factors like that. But I think it's a really good question, and I'm not quite sure if that's going to be discussed at the policy roundtable, but it sounds like that would be a great topic.
If I could just a very quick follow-up. I'm not sure. I understand what you're saying about the averaging, but I think with these sort of system externalities, right? The averaging over the course of the year may sort of hide more than it reveals if you have to sort of plan in a costly way for those peak loads. But thank you. Thanks for the answer.
Okay.
Dr. Kim.
Brad, thank you so much as usual, outstanding work and outstanding presentations. And in your base case analysis, you presented lifetime analysis, which is pretty typical when we're thinking about interventions affecting, patients in the long-term outcome, like chronic disease that most of ICER evaluations typically focus on. The COVID-19, we could make argument whether it's kind of a chronic impact versus it's really short-term interventions affecting short-term disease. And David's earlier presentation also talking about, and we're kind of looking at 6 months effectiveness, and then the next year we may need a revaccinations, right? So, and then in the scenario analysis slide that you kind of went over a little bit quickly, but one scenario you actually look at the 5-year time horizon, and then obviously cost-effective ratio becomes much less favorable because you don't capture the downstream benefits. So I like to hear your thoughts and then kind of a little bit rationale that how we should understand this kind of a lifetime value versus 5-year, even whether kind of we should look at just a 1-year value of the COVID vaccine.
Yeah, it's a just fantastic question, David. So thank you for that. You are right that scenario analysis 3, for those of you who aren't aware, if you look at the table in the report, we do go above that 100,000 per EVLY estimate. And the 5-year really represents the cutoff of the highest amount of quality of life and cost impacts from the long-term sequelae. What it does not include is my response to Don, which was, what about the life that would have been lived had you been in that first year? If you had not died in that first year. So over the 5 years, we're only including that you would have lived an extra 5 years had you not died in the 2026 to 2027 season. But the lifetime, and this is really just ICER's value assessment framework, the lifetime would then include all of the life based on an average American survival. So they could die in 10 years or 15 years or 20 years. So we include all of that survival. That's why I think it's more appropriate as the base case to include that, because a vaccine does have an effectiveness against death, which we directly model against not having the vaccine. So I think, in my opinion, that is a more appropriate base case. However, it's important for you to characterize thinking about a vaccine in a short-term way. You might end up at those higher cost effectiveness thresholds, the kind of the ones that Dr. Prosser just spoke about, that it may kind of creep up to 150,000. So I don't know if that answers your question, Dr. Kim, but
yeah, thank you. Thumbs up. Professor Conti, go ahead.
Thank you, and thank you, Bo. Excellent job. I have a question again about how to think about high-risk populations in this. And the population that I was specifically interested in are folks who are in nursing homes or long-term care settings. How do you think about the evidence and it's the overlap between high-risk comorbidities or older adults and that specific patient population?
Yeah, that's a good question. I'll probably lean a little bit on David after I give you my answer. But my thought to that was, and we did focus in right on hospitalization. The criteria for that are based on at least one comorbidity. So if patients are specifically in a nursing home, we might see a higher risk of a hospitalization, 2 or 3 comorbidities potentially. Then that would actually push our cost effectiveness estimate even further downward, because we're avoiding really severe events. But it's unclear, you'd almost have to do another subgroup analysis where that at least 1 becomes at least 2 or at least 3. And then how that would play out in the pooled results, I would think would push the ICER downward further. But again, you'd have to characterize that in a way that I think made sense clinically. And that's where maybe I'd lean on David to chime in if he had any thoughts on that. So,
yeah, would welcome anything from David, or there's also experts that may want to weigh in on this issue around subpopulations.
Why don't it felt to me like there were 2 pieces there. and I'll comment on one, and then maybe our patient experts can comment on the other. So, one issue is, I think that age and comorbidities travel together. And that actually causes real problems in understanding how good the evidence is for vaccinating people with comorbidities, because if you get more comorbidities as you get older and the vaccines are more valuable as you get older, if you ask me how sure I am that if you have a certain comorbidity as a 20-year-old, you need the vaccine, it's actually really hard to sort that out of the evidence. So I just want to acknowledge, because I didn't have time to talk about that in my presentation, that that's a reality, that I'm less sure of that than some of the other things in our report. On the issue of thinking about, places where there have been horrendous levels of deaths, like nursing homes, I will turn this over to our other experts, including patient experts.
Feel free to just unmute yourself if anyone wants to respond.
Just wanted to add to that the scarcity of evidence around vaccine effectiveness in immunocompromised populations, for this vaccine. And what we know from other vaccines is that they're likely to be less effective in these populations. And so then that would, despite the higher burden of illness, would move the ICER in the different direction if the vaccine were substantially less effective in these populations, like we think it might be. But again, the evidence is very scarce here.
Thank you. Seeing any hands up. Dr. Falk, do you have a comment or a
Yeah,
response?
sorry. Maybe another big data point. When we published our guideline for immune-compromised patients, in fact, just to put a little bit of a counterpoint on that, they are really hard hit on COVID. So once you start rituximab or something like that, if you get vaccinated before that, this is a major difference in baseline risk. That your risk goes so high for poor outcomes that vaccination becomes way more effective. So we had no problem showing really substantial effectiveness in immune-compromised populations.
Thank you. That is helpful. Dr. Huang.
It's nice back and forth about differences in baseline risks, and then nice conversation around the variable effectiveness of the vaccine in this kind of older, sicker population. The other thing is, I know these models have historically not accounted for spread, but I mean, during the course of the COVID pandemic, there was a lot of evidence that basically lots of the bad outcomes in the nursing homes was due to community levels of COVID-19 that through staff members who were and spread the virus during the pandemic to older adults in these nursing homes. So that would require, and actually, so staffing level vaccinations within congregate settings is a whole nother topic, would require a different kind of modeling, agent-based modeling approach to account for that. But very clearly a very important population that's coming out of this report. But still, quite a bit of uncertainty, right?
Yeah, I think that's a really good point, especially that's almost a whole separate research question, It would be really fascinating actually to build that model. Yeah. Thanks for that.
Can I ask a question? This is sort of it's sort of for Brett, but it dovetails with the clinical effectiveness stuff. So anyone feel free to weigh in. Obviously the way we do these two sides is like, there's clinical evidence and then economics is to sort of weigh in on whether it works and what the price could be or should be. But you sometimes actually from the cost effectiveness modeling get some insight into the effectiveness just because the modeling, as you've referenced, kind of puts populations together and merges clinical outcomes in a way that can direct the eye. And I just note during your presentation and through the report that the quality difference is 0.002. roughly between that's about right. You're not nodding, so I think about right. 0.002. And if I've got my back of the envelope math right, that's like slightly less than a day over your lifetime, right? Just in terms of, I mean, do you agree that kind of shows if there's a difference here, it's a pretty small, less than 1 day of extended, fully healthy life over a lifetime.
Yeah. Yeah, I mean, I tried to point that out in the base case results just to note that we're really talking about a very small difference, both in the numerator and the denominator. So it's pretty unique actually for, I think, for an ISA review, and I've been doing this for 10 years now. It's you don't often see those, right? Just the small difference. But we also have to remember, Jason, that there's the cost offset from the hospitalization, right? In addition to the quality of life benefit. The other thing to note is that what we're averaging this over a huge group of people. When you look at the subgroups, the differences are much, much bigger in terms of the health benefits. So if you wanted to, you can actually go look at the subgroup in the supplement of the high risk above 65, above 50. Then you start seeing where the pooled results, if you disaggregate those, where are those coming from? So I'd urge you to look at the supplement if you haven't already for those, because I think that's a really important point.
Yeah, big differences in different subpopulations. Dr. Gold, and that'll be the last one because we got to move to public comments.
Okay, just a quick question. Does anybody have any insight as to the latest version of COVID that's coming down the pike and the the ability of the vaccines to anticipate what that is going to be protective? Is there any information about that from any place where COVID has begun to raise its head again?
There are two strains that people have been talking about lately, and the vaccine they chose was against one of those. They didn't pick a bi-strain vaccine this time around. So cicada, which was being talked about a few months ago, isn't in the vaccine and hopefully won't become a predominant strain because that isn't the version that they're aiming at. And as per my understanding, Lisa, I have that right? Okay.
Yep, that's right.
Thank you all for the good questions, the great discussion. We are 2 minutes behind, which is sort of on schedule.